Hello, I'm Kerry from the Patient and Public Involvement team at the Royal College of Obstetricians and Gynaecologists. Thank you for joining us for our webinar on premenstrual dysphoric disorder, which we'll be referring to as PMDD. So tonight I'm joined by two people who have a wealth of knowledge around all things PMDD related, consultant gynaecologist Dr. Panay and Laura Murphy, who's the co-founder and director of the fantastic support organisation Vicious Cycle. So I'll hand it over to you two to introduce yourselves and tell us a bit about what you do. Okay.
My name is Panay. I'm a consultant gynaecologist. I work at Queen Charlotte's and Chelsea and Westminster Hospitals. I'm also chair of the National Association for Premenstrual Syndromes. I've spent a professional lifetime, I would say, dealing with hormone-related issues. I suppose my interest started when I was working with Professor John Studd, who is one of the pioneers in this field, in fact. Over the years, I have managed a busy clinical workload, so we have busy clinics where we see women with PMS at both Queen Charlotte's and Chelsea and Westminster Hospitals, and also worked closely with my fellow trustees of the National Association for Premenstrual Syndromes to improve awareness of the condition and also to find new ways of managing a condition which I think is very poorly understood and often very poorly managed. And even though I believe that we are making some progress in this area, I still think there's an awful lot of work to be done in terms of education and research. So I hope to devote the next part of my professional life in improving the situation further.
Thank you. Laura?
Okay, so my name's Laura Murphy. I suffered from PMDD myself, about 20 years, 17 years of those undiagnosed. I am on the board of directors and I'm the social media team lead for IAPMD, the International Association for Premenstrual Disorders. And I also am co-founder and director of the Vicious Cycle project, which is a patient-led awareness campaign.
And can you tell us a bit about what Vicious Cycle do and some of the work that you've done recently?
Yeah, so we are a global collective of patients, and there's 7 of us in the core team. So we have a USA coordinator, we have an Australian coordinator, I'm the UK coordinator, and we basically try to push PMDD in every hole we can. So we are very, very active on social media. We got PMDD relisted, for some reason it's taken off, on the Mind website, and worked with Mind as patient advisors to ensure all the information was correct and evidence-based. We find a lot of journalists and signpost patients to them to take part in media campaigns. We've been on BBC Breakfast, LBC, Radio 5 Live, Radio 5 News, and just try and bring attention to PMDD wherever we can. So we work very closely. It's complicated because I work for IAPMD and very closely with IAPMD to raise awareness and make sure that it's evidence-based information that's being put out there. Because unfortunately, like Dr. Panay was saying, there's a lot of misinformation and a lot of bad management of PMDDs, making sure that people are signposted to accurate information.
I think that's a very key point that Laura makes, that education is one of the most important things. And a couple of years ago, myself and colleagues produced Green Top guidelines for the Royal College of Obstetricians and Gynaecologists on managing premenstrual syndrome, particularly the severe type, one of which is PMDD. And the National Association for Premenstrual Syndrome has reproduced the guidelines which are available to download from the website. And so the organisation is there for both healthcare professionals and women as well, in order to make sure that everyone fully understands this condition as much as possible.
I have to say, in the UK, we're so lucky. We really, I think, thanks to Dr. Panay and colleagues, we're so far ahead of other countries. You look at Australia, you look at America, Canada, they are way behind what we what we have and what we can offer. To have treatment guidelines as a patient is huge, because you actually have some leverage in pushing forward to get a diagnosis and to get the right help. So yeah, very grateful for that.
And I know we've got a range of people who are tuned into this session, some who may not know a lot about what PMDD is. Nick, can you give us a brief overview of what it is?
Well, PMDD, strictly speaking, is the American Psychiatric Association's definition of one of the severest forms of premenstrual syndrome, which has a significant functional impairment. It affects people's ability to function personally, socially, professionally. It is a strict diagnostic criterion from the American Psychiatric Association, and there are other types of premenstrual disorders which are equally disturbing for women as well. For instance, there are situations where there is an exacerbation of a pre-existing psychological disorder, a background psychological disorder, which can be equally disturbing. There may be significant PMS or PMDD side effects from treatment with certain types of contraceptive pill or certain hormone therapies. Sometimes symptoms can occur in the absence of menstruation. For instance, if a woman's had a hysterectomy, they can get what John Studd always used to refer to as ovarian cycle syndrome, where the symptoms occur in the absence of menstruation, but the ovaries are still there, and the changes in hormone levels are triggering symptoms in women who are vulnerable to those symptoms.
And so we've had the kind of medical definition. What's it like day to day for someone living with PMDD?
I have to say it's a spectrum, so not everyone suffers the same in the same way. In my 20s, I think I suffered for probably 2 or 3 days a month, and then as I got into my 30s, I had the marina coil, and that was a real tipping point for me, and that meant I was losing about half a month each month. So for me, the symptoms were depression to the point where I couldn't get out of bed, anxiety, suicidal ideation, so not wanting to exist anymore, or wake up in the morning. It started nearly in my 30s, like I was going through bereavement every month. I just sob and not be able to stop crying, binge eating. Some people have insomnia. I had hypersomnia, so I'd sleep for 14 hours, wake up, have breakfast, and couldn't keep my eyes open and have to go to bed for a 2-3 hour nap. Makes it sound fun, wasn't? Just any PMS symptom and take it to a max where it's at a point where it's uncontrollable and you can't function properly. So when I was younger, lots of panic attacks and anxiety attacks, but I didn't know about PMDD then. I just thought I was broken and weak, which is a very common story from women and people living with PMDD, unfortunately. So yeah, everyone is different, but depression and anxiety, there are key diagnostic criteria which can be found online. Yeah, it's really hard. It's really hard. It's like being hit by a steamroller once a month, and then you get back up again, only to face it again the next month. And I would say I suffered from depression as well in my life, and that would last for about 6-7 months of quite chronic depression, but you would be building towards getting better. And I think that's the case with lots of mental health issues. You are working towards recovery, whereas with PMDD, it would hit and you just get back up on your feet, and you know, you can look at the diary and you can see the date is going to come again, and you can look at as soon as you start feeling that brain fog, that irritability, that's it for the next 2 weeks. You're going to get dragged down under it. So it's really difficult.
And I think that's really important to highlight, that it's often the emotional and the cognitive problems which are particularly distressing and particularly impair people's ability to function. Because often the condition is sort of belittled by some, there's a little bit of breast tenderness or fluid retention, and the physical symptoms are mentioned. Actually, most people can cope with the physical symptoms, but it's often the overwhelming effect of the emotional symptoms that makes it so difficult to function. and is out of the control of the sufferer. I think it might be.
You can't outthink it. You can't You can't put on a positive frame of mind. It's not like it's not something you can kind of duck out under or outthink. It takes you down, however you're thinking, however positive you are. And there are things you can do, to try and help that in terms of stress reduction in your good weeks and not taking on too much. But at the same time, if it's happened, it's going to happen. So it's not their fault.
And it must make life very difficult in terms of work, relationships, and
it has a real impact. It's massive.
There's been some very interesting work at Harvard University and other places looking at the potential genetic cause and etiology for the condition, which means that there is a sort of organic problem. It's not something which is really emotional, that there are differences in the way in which the hormone receptors are coded in PMDD sufferers compared to non-sufferers, which means that makes them more vulnerable to the hormonal changes which occur on a monthly basis. So every woman has similar hormonal changes, but because of the different ways in which these receptors are coded, it can have very different outcome.
So I think, the phrase we use is a severe abnormal reaction to normal fluctuations. So hormones are normal.
Yeah, so there isn't a magic hormone test that can be done. Although sometimes you get associated conditions like polycystic ovarian syndrome where there are still sort of cyclical changes. And also the approach to the menopause transition when, again, hormone changes are more exaggerated and are more likely to trigger the symptoms. But for people who don't have that genetic vulnerability, it doesn't affect them as much.
I think it's important to say, so it affects around 1 in 20 women and assigned female birth individuals, and that's at any point during their reproductive lifetime. So for some people, so for me at 17, taking the contraceptive pill, it triggered. For other people, they may not suffer until they've had children, or for some, not until they hit perimenopause, until those hormones start jumping up and down, it can trigger it. So it's not something that people necessarily have from puberty, although I think that's very, very common from what I've seen from people. It's,
That's another time, puberty and hormonal change, which can affect vulnerable people, and the other time is postnatally. So as the hormone levels start to drop postnatally, then that can lead to postnatal mood swings or depression, and then as the cycle comes back, the symptoms can get worse. So pregnancy itself, the second half of pregnancy, can actually be protective because hormone levels are quite stable at that time.
A lot of people say it's the only time they've got normal in their adult life, so they like being pregnant.
And it must be quite difficult for women in that postnatal period when you might have postnatal depression as well. And
I think it's one thing it being difficult, but it's also not knowing that PMDD exists. We see that a lot. So we have people who don't find out about it until their children are a bit older, so they don't understand why once a month they felt like they were losing grip on reality and really, really struggling. So they may be diagnosed with postnatal depression, but it's not an accurate diagnosis because it comes and goes. And they don't. We see people all the time that have been referred to a psychologist, and then they see them on a good day after their losing weight, and they're like, "Yeah, I'm fine now." So they get discharged, and then 2 weeks later they're back in it, and they don't understand why that's happening. So it's not being picked up on, and again, that's down to awareness and training of healthcare professionals.
Yeah, it's picking up the clues, and also occasionally it can be really helpful, not when you're just doing research, to actually ask, want to keep a symptom diary for 1 or 2 months, which will usually sort of clearly demonstrate the changes which occur that perhaps have been missed over the last 15 to 20 years, either by the individual or their partner or by their healthcare professional. It's just been put down to bipolar disorder or pure depression or personality issues, but in fact, you can clearly see that there are hormonal related mood changes.
And you can get apps. There's MeV PMDD app, which is a PMDD specific tracking app that ties you into the IAPMD peer support service. So they offer a free service to anyone who needs guidance and informational support with PMDD. So it kind of, you can tap into that through the app quite easily.
There's another one called Clue and another one called Prementrix, but that one is PMDD specific, as you say.
And you can get a print off version, can't you, from the NAPS website or IAPMD website. So they're there.
And so in terms of diagnosis, we've had a pre-submitted question through from someone in Northern Ireland who says their GP hasn't heard of PMDD, and how can they best approach them about this if they think that they're experiencing some of those symptoms?
Repeatedly, I think you can go armed with information, like Dr. Panay was saying, the Green Top guidelines and the NAPS guidelines, which can be found easily online. You can download them, and if your doctor isn't listening to you, you have to just see another doctor. If they're not listening to the information, the guidelines that are there. Personally, I've had to put in a complaint before. I've stuck to informal because I do think it's down to education. So I hope that due to that informal complaints, education took place. But sometimes you just have to keep knocking on more doors until the right one answers. That's a very, very common story, unfortunately.
And so the patients that you see have been referred from their GP, and how's that kind of worked in terms of diagnosis and referral?
Well, sometimes they're referred because of and there are a lot of very good GPs out there, has made the diagnosis, but they're not quite sure how to manage the condition. And then we start to talk about sort of treatment options once the diagnosis has been confirmed. But other times they're referred because it's really unclear what's going on. The patient has been labelled with bipolar disorder, but she herself has noted that there is a cyclicity and has kept a symptom diary and has insisted to the GP that they're referred on to us. And so, those are the situations that we want to avoid in the future. And I think it is down to education and picking up those clues. And then once we start looking into the history more clearly, we can see the times that we've talked about premenstrually, postnatally, perimenopausally, that there are particular peaks, if you like, in a woman's lifetime symptomatology when it's obvious that this individual has hormonal ability to her symptoms. And I've had women who weep at the fact that finally somebody's sort of taking them seriously and confirmed the diagnosis, and saying, right, we need to sort this out, and then talking about evidence-based treatment options, and that's the important thing that we do sort of treat with evidence-based options. I think the scandalous thing is that we still don't have evidence-based options that are actually licensed for the indication, and that's a complex issue related to the drug industry not particularly wanting to research this area, but also perhaps the area itself not being taken sufficiently seriously in the training curricula, either in undergraduate or postgraduate sort of training curricula. We are currently undertaking a study at the moment looking at a substance that modulates the effect of the GABA receptors in the central nervous system. And if women are watching this, or any healthcare professionals, and they want to let their patients know, if they Google aspirina, then they will be able to find more information about the study.
And you spoke about some of the treatment options. Are you able to give a bit of an overview to that for people who might not be too aware of some of them?
I think, as Laura was saying, it's really important to get the basics right. First of all, lifestyle, diet, exercise, sort of minimising alcohol,
stress reduction.
Stress reduction. And people are finding things such as mindfulness and cognitive behavioral therapy very helpful. That may be enough in itself, but usually for the severest form of PMS or PMDD, a more medical approach is also required over and above that. And broadly speaking, there are two sort of categories of treatment. One is a more sort of psychological approach, the use of antidepressants. The other is a more gynecological approach, where we can stabilize the hormone fluctuations that are triggering the symptoms. Now, from the antidepressant perspective, the nice thing about using antidepressants for this condition is that they don't need to be used continuously. They can be used just in the second half of the cycle, or even symptom phase, just at the time that the symptoms occur. And they work straight away, as opposed to using them for chronic depression, where they need to be used for a few weeks before they start to work. And it also means that you can discontinue without getting side effects, withdrawal symptoms, because dependence hasn't occurred. From the gynecological perspective, there's been quite a lot of research looking at different contraceptive pill options. Many pill options have not been fully effective because the type of pill that's used can in itself trigger the premenstrual symptoms, and there are some pills that are more female-friendly than others, those with more female-friendly types of progesterone in them. The drospirenone-containing pills, for instance, such as Yasmin and Eloine, tend to be better tolerated than the androgenic pills like microcolum and low estrogen.
I think about the first-line therapies work for about 70% of people, I think is the research. So for a lot of people, they might not need to be referred to a gynaecologist because Absolutely. It can be done at GP level. It is that sort of 30% that then would need to go on and try different therapies. And unfortunately, with those therapies, I went through the whole lot. It doesn't work for everyone. There's no one size fits all. Some people, I reacted really badly to all birth control, oral and the Mirena. So it is trial and error, and as a patient, listening to your body and knowing if it's working for you or not. Like, don't try and fool yourself that you have to put yourself through hell if you're reacting really badly to something.
So the treatment options for situations where the symptoms are more severe include hormone therapy and the sort of HRT that we would use to treat menopause symptoms, but at a higher dose. So rather than trying to replace hormones that are absent, what we're trying to do is stabilize the hormone fluctuations. Sometimes we even have to switch off the cycle completely with a monthly injection or a nasal spray, which mimics menopause, makes the body think it's in menopause, but we don't want to replace cycle-related symptoms with menopause symptoms, and so in that situation, we give back hormone therapy. And then for those women with the severest symptoms, where they've had perhaps some benefit from this treatment, but not complete benefit, or where they don't want to be tied to cycle suppression treatments long-term, then surgical intervention with hysterectomy, and important that the ovaries are removed, otherwise the symptoms will usually continue, and making sure that those individuals have adequate hormone therapy. And with that sort of intervention, I would say, assuming you've done all the necessary sort of diagnostic checks and truly individualized, it is extremely effective in ameliorating the symptoms.
We've got some great comments and questions coming through. Just think a few people wanted to follow up on something. Laura, someone's asking the 70% that you mentioned.
So 70% of those with PMDD will find that first-line treatments, so and or SSRIs and or birth control. So some people it's a combination of both, for some people it's together, but they will find that that's effective enough to control their symptoms. And we see that quite a lot. We have a lot of people come to IOPMD who try the SSRIs and you never hear from them again. It works wonderfully for years. For some people, again, it's so hit and miss. For some people, they find it really works for about 5 years, 6 years, 7 years, but whatever it is, 6 months, it could be any amount of time, the efficiency wears off. So for a lot of people, it's a bit of a combination.
And someone's asked Nick about the research study you mentioned earlier. Can you just tell us what that was called again?
Well, we're working with a company called Acerina, and the substance that we're looking at is sepranolone. And what it does is it blocks the receptor, they're called the GABA receptors in the central nervous system. So the theory is that when progesterone is converted to one of its metabolites, allopregnanolone, some women find that relaxing and calming, but others find that it causes depression. So for those women in which it causes depression, if you block its effects, then that can prevent the depression from occurring. And some of the preliminary studies that have been done with it have shown that it is very effective for PMDD, and we're continuing to do studies. We're doing a phase 2 clinical trial, as it's called, to ascertain whether the effects of this particular blocker, if you like, are better than placebo, because it's always important to do these studies to make sure, because there is a strong placebo effect to begin with, which often wears off. We're looking at 2 different doses versus placebo in a clinical trial.
So I think they're taking on people in London, Stoke-on-Trent and Liverpool.
Yes.
And it's quite strict criteria. So I know quite a lot of people are getting upset they haven't accepted, but it is a very tight criteria.
The information, if they go through the Acerina website, then they will see what the tier are. There's a little questionnaire that they fill in.
So we've got a few other questions that have come through, and quite a few comments about education and how can we get the message out there to younger women about menstrual health in general and PMDD.
So in terms of the menstrual health, so we've worked with Endometriosis UK, and so from 2020, PM will be included in the menstrual education in schools. So very carefully mentioned, as in, I think they're going to be covering what's common and what's uncommon. They want to stay away from what's normal and what's not normal. So, you know, for example, crying, wanting ice cream, PMS, any, you know, and there's a certain sort of threshold where beyond that you would want to get help because there's other things. So really sensitively, and that will be in every school in the UK from 2020. So that's exciting.
I think the education has to start at school, and I see a number of adolescents who, you know, have been doing terrible in their schoolwork, exams, and, you know, falling out with their families. And once they're appropriately treated, you know, I've had a number of them turn into sort of straight A students, Oxford, Cambridge, etc. But it's about recognising it. And there's often a fear about treating younger women, but there shouldn't be, you know, because this is one of the times of peak prevalence.
Yeah, I think we're so lucky nowadays with the internet, because we see women all the time that have gone 20 plus years undiagnosed. So it's pretty amazing that there's, you know, I wish I'd had, I was a teenager, if it wasn't until I was 35, I even heard of PMDD. So it's great that young people are able to get to proper help, and I think that's what Vicious Cycle we want to do. We want to make sure that no one is going through it alone.
And in terms of doctors training, Nick, we've had some questions about getting the message out there to GPs and other healthcare professionals about PMDD and how that can be more part of doctors training. Have you got anything around that you'd like to add?
Well, the first thing to say is that it's got to be there in the curricula, in the undergraduate, in the Royal College of General Practitioners curricula, RCOG curricula, etc. You know, it's got to be there so that primary and secondary care learn this as a core skill. That is aiming to educate through the guidelines that we issue. And we have a number of meetings that GPs attend. We try and have at least 2 meetings a year, attended by primarily GPs, also some secondary care doctors as well. We distributed our guidelines to 10,000 practices around the country.
And can you explain to us a bit about what the guidelines actually are?
Well, the NAPS guidelines are essentially a condensation of the RCOG guidelines in more sort of bite-sized chunks, if you like. Trying to deliver the key messages of making the diagnosis an evidence-based approach to the problem. As I say, it's frustrating that there aren't any preparations that actually work, that are specifically indicated for the condition. But if we give people the confidence of being able to use SSRIs or hormone therapies in this context, then it's more likely that people will be put onto the evidence-based treatments. You'll often see women put onto the mini pill, for instance, which doesn't work and sometimes can actually give them continuous PMS, PMDD symptoms rather than getting rid of them. So it's about getting the key out there that you need to try to suppress that cycle in order to get the effective treatment, and that it's about using the right types of hormones. So the guidelines are essentially there to provide confidence in terms of managing the condition in an evidence-based way.
I should say as well, the first UK PMDD conference for patients took place in Bournemouth in April, and so that's pmddandme.com, .co.uk, and that's Alice Girling. So she's going to be arranging a doctor's day, a professional's day on Friday, and then one for the patients on the Saturday.
And that's next April.
That's next April, and it's all online, so we'll be working.
No, that's great, and it is all about working together. We're on pms.org.uk, and there's information about our forthcoming meeting in Manchester. So, all are welcome.
We've got some more questions coming through. So we've got questions. Someone's asked, how does everyone work with this debilitating emotional pain?
I didn't. I temped for years and years. Cried in a lot of work toilets, walked out of a lot of jobs, had panic attacks, and this is what I knew about PMDD. So I just thought I was quite rubbish, to be honest. I didn't hold down a full-time job for many years and just scraped by financially, to be honest. Had to move back in with my parents. I didn't. There's, if you go to seeherthrive.com, that's Claire who we work with. So she's an employment psychologist who has PMDD herself. So she's put together lots of help sheets and webinars for finding coping mechanisms for working with PMDD, and with her we do employer training, so employers can know how to best make adaptations for the workplace. So for some people, it's working with your employee if you have real irritation, just to be able to maybe to wear earphones for a couple of days a month, just to be able to get your head down and work. For some people might be working from home. It really does depend on your role in what you do. But I can just say for me, I crashed and burned, to be honest. And some of that is down to the fact of how severe it was, and some of it was down to I didn't know about PMDD, so I never knew what it was going to be coming back or taking me down, because I had depression as well. So it's all a bit of a mess, to be honest.
It's so important that the employers themselves know about this condition and can make allowance for it. I think the work that you're doing, the work that we're doing with NAPS to try to educate employers as well as healthcare professionals is vitally important.
I think sometimes it just needs some adjustments, and it's finding what works for you, really. But yeah, seeherthrive.com, that was great. She gets it because she's got PMDD herself.
So you mentioned when you found out about PMDD. How did you find out about PMDD?
I had seen my GP, who had told me that I was lucky I wasn't a witch, because I was lucky I wasn't alive in the Middle Ages, because they would have was a witch and burnt me alive. And I was seeing a therapist at the time because I was quite unwell with the marine coil, and she's the one that said to me, you know, no, this isn't just PMS, like, trust me. So I went home and I googled severe PMS and popped PMDD, and it was actually, you know, we call it a light bulb moment, tick, 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 tick. I just had everything, joined a few support groups on Facebook, the UK PMDD support group, and started realising that everything I've been going through for the last 17 years, you know, I always thought it was quite unique, and you realise it's really not. There's so many people who go through exactly the same every month, which is really important, I think, to have that support and understanding. It's at the conference during the IAPMD one last year in America, we were saying, you know, it's really amazing to be in a room full of people who understand your language. You know, you can say I'm 24 and they go, oh, okay, do you need anything, or do you need to be left alone? You know, there's no offence taken. People understand the language, and having that sort of peer support really, really important. But yeah, Dr. Google was for me, and even when I went to my doctor, she wasn't particularly interested in it, and we hear that a lot. It's an American term for PMS. It's not real, can't be that bad. It's pretty common, but I think we did a really small survey, and I think it was about 66% of people that found out about it online rather than through a healthcare professional.
Well, hopefully with guidelines in place, things might become a bit easier for women seeking a diagnosis.
I think education is where it's at. I think the guidelines are one thing to arm yourself with, and we are so lucky. Always say that, because people always say, oh, I wish it was like America. And you're like, you know, we are so far ahead, we're really lucky. But I think it's education and knowing how to spot it, because I think once you know about it, you spot it pretty easily. You know, I can usually spot by reading something a mile away. I kind of think, you know, quite likely PMDD. So yeah, education.
And I think it's about, I mean, my wife's a GP, and I know how hard she works. And I think it's about giving GPs the time as well. You know, how can you know, make a proper diagnosis and institute treatment within a 7 or 10-minute appointment? So I know that there's talk about increasing GP consultation times as well. So all of this, you know, will help.
Yeah.
So if we have women out there watching who think that they might have PMDD and they've made a GP appointment, what would you suggest them that they go along with to make the most out of that appointment?
We always say, so when people join the UK PMDD support group, we give them a link to download the NAPS guidelines, and we give them the app to start recording their information. And we tell people, but a lot of people don't listen, is to read the guidelines, print them off, get a highlighter and read it until you understand it. Because quite often you're going to need to advocate for yourself. So you're going to need to know that you need to ask for blood tests to rule out a hormone imbalance or a thyroid disorder. You're going to need to know that if they come back clear, that doesn't mean you don't have PMDD, you know, because they don't show anything. Yeah, information and tracking is really important, and showing the severity of.
And so you're tracking your moods and physical symptoms as well?
Yeah. There's the online trackers you can get, kind of include everything.
And how it relates to the periods. And that's really helpful for us, because then if we can see the pattern very clearly, then we can start treatment sooner rather than later. We don't have to send people away then to fill in more diaries. We can get started immediately. And that's usually met with a certain amount of gratefulness.
Yeah.
That, you know,
I think I have to say,
such a delay in them seeing a doctor to begin with.
I think I have to say, after 17 years of waiting, the first time I ever felt understood by a healthcare professional was sat in front of Dr. Panay. I stopped in the street outside, and I remember I was saying earlier I'd done full spreadsheets with colour coding, you know, and everything, because I was just so desperate to get the point across. You know, it's important to be prepared.
And the patients often know more than most of the doctors by the time they get to see our clinics in secondary care. Unfortunately, there aren't many sort of specialist PMS clinics around the country, but there are a lot of specialists who have an interest in this area. And again, at MAPS, we've been signposted women to the specialists that we're aware of around the country. We co-manage a lot of patients at Queen Charlotte's and Chelsea Westminster with Michael Craig, who runs the psychoendocrine clinic at the Maudsley as well. So that's another centre of excellence. And Professor Sean O'Brien up in Keele, although he's retired recently, but other colleagues of his have taken over the work, excellent work he's been doing.
And we've had a question through about working with colleagues in other professions in terms of psychology, psychiatry. Is that something that happens when you have a referral, or what kind of stage might that happen?
Well, I think it's important that we do have a sort of multidisciplinary approach to managing the problem. Because I mentioned earlier, often there may be a background psychopathology, but with a premenstrual exacerbation of symptoms. We have a psychologist, Danny Singer, who works with us at Queen Charlotte's and Chelsea Westminster. She's also at Northwick Park. A number of our patients I co-manage with Professor Michael Craig. He should be a professor, but his excellent unit at the Maudsley. And we also occasionally have to manage situations with physicians as well, because we may be seeing individuals have an exacerbation of pre-existing medical condition like epilepsy and asthma. We also have nurse specialists who, I work with a nurse consultant, Claire Malone at Chelsea Westminster, who has the same sort of level of knowledge and expertise. And it's always helpful, I think, to work with professionals that perhaps come at things from a slightly different angle and help to truly individualise the care that we give our patients.
I would say that's the ideal, that's the dream. And I think we see people who perhaps can't be referred to Dr. Panay's clinic who don't have that luxury, so they'll be sent to psychiatry and be waiting a long time for an appointment, bounce back, discharged when they have a good day, then maybe sent to gynaecology, waiting a few months for exam, and make an appointment. They don't understand PMDD, or they think it's a psychological problem, they get discharged, then they get back to, there really needs to be better joined up working. It really does.
And do you know the average length of time for diagnosis?
12 years is the current research we just did on PMDD. It's a long time.
I think we've got a few more questions. We're nearly up to our end point now. So we've got a few questions from people who aren't sure if their treatment is working for them. What would you suggest in that case?
Sorry, I was just reading the one that says where can you find help in America. So on the IAPND website, there is a Find a Doctor map, and you can just input anywhere in the world. It's kind of filling up, it's growing, so patients can look for someone who is recommended by a peer, someone who's seen them for PMDD. So there you go. And the one people are saying the treatment aren't working, it's really about being under the right doctor. It's really about being under someone who knows what they're talking about.
I think we've talked about using diaries to make a diagnosis, but I think it's also important in terms of monitoring the treatment. I mean, first treat the patient, and the patient tells me is the most important thing. But I think the diary is also quite useful. Sometimes you can see improvements that perhaps haven't been noticed, and other times when you're not seeing improvements, you have to think to yourself, well, have I made the right diagnosis? Are there other things that I should be considering? And also perhaps changing the treatment as well. Perhaps going from pill to hormone therapy, or from hormone therapy to complete cycle suppression. In the guidelines, we have an algorithm with different levels of treatment, and it's about choosing the right level for that individual, and also moving within those levels to get the right outcome.
I think we're coming to our end point now. I just want to say thank you for everyone for your comments and sharing your experiences as well. We will all have a look through your comments and your stories too. And thank you for joining and all your questions. We will be sharing this on our YouTube channel, and we'll be in touch with all of you to let you know some of those websites that we mentioned and areas you can go to for support and more information. Were there any final messages from?
I was just going to say that so we are Vicious Cycle making it visible on Facebook. So if there's quite a lot of questions we haven't answered. If people want to message the inbox there, then I'll make sure we signpost you to the right place.
And any final messages from you, Nick?
Well, the first thing to say is for any sufferers out there is don't be put off if you don't initially get the right response from your healthcare professional. Find another one if you have to, and make sure you get referred if that particular individual can't understand or deal with your symptoms. The other thing to say is that it's a condition which isn't that difficult to treat once you've actually made the right diagnosis, but it's about getting the diagnosis right, and that's why sooner referral is better than delaying things. And thirdly, if anyone, either patient or healthcare professional, does have further questions, we do have on the PMS sort of website an opportunity for people to ask the experts, and we can get back to either patients or healthcare professionals.
That's lovely. Well, thank you both so much for joining us, and we hope you found this webinar useful. And thank you very much. Bye.
Thank you.